Welcome. We are delighted to present this series of educational videos, Pituitary 101, featuring Dr. Louis Blevins, a program exclusively produced by Pituitary World News with important information about the systems that drive pituitary function and, importantly, how those systems are affected by pituitary disease. Here's Dr. Blevins.
Greetings and welcome. I'm Dr. Louis Blevins of Pituitary World News. Today we'll be covering the hypothalamic-pituitary-thyroid axis in episode 3 of Pituitary 101. I like to think of the hypothalamic-pituitary-thyroid axis as one of the first ones that I often use to discuss with medical students and residents and endocrine fellows, and that's why I'm sharing it first in this series. The general notion that people have about the thyroid axis is it controls your metabolism. It certainly is largely responsible for the metabolic rate, but thyroid hormone does so many different things in all the different tissues. That's beyond the point of this discussion, but we'll review the hypothalamic pituitary unit and how that controls thyroid hormone levels and talk about some really interesting things that one needs to understand about pituitary thyroid function, and it also gives insights into pituitary function to delve deep into some of these different areas of the way this unit works. I'll start with this slide. This is a schematic of the hypothalamic pituitary-thyroid axis, and you can see here at the very top the brain does have control over the hypothalamus and interprets a lot of different signals. In this system, probably it's looking at body temperature, outside temperature, etc., that relate to some of the thermoregulatory and heat-generating properties of thyroid hormone. But there are lots of different factors. If you're sick, you're going to probably downregulate some of this system as well. With that said, there are neurons in the hypothalamus that produce TRH, or thyrotropin-releasing hormone. Those travel down the pituitary stalk through the blood supply and find the TSH-producing cells in the pituitary gland and cause the production of TSH. It's a protein hormone, 2-unit protein hormone actually, and it has to be modified after it's produced by the DNA to be biologically active and to be secreted appropriately in response to that signal of TRH. And TRH has a lot to do with that process of modification of the TSH molecule. There are also hormones in the hypothalamus that produce somatostatin, and somatostatin can inhibit TSH production. Dopamine and dopaminergic drugs can also inhibit some TSH production as well. Once the TSH is modified and secreted on an as-needed basis, it travels in the bloodstream to the thyroid gland, where it leads to the production of T4 and T3. Most of the T3 that's in the circulation actually comes from peripheral conversion from T4 to T3 in the liver and the kidney. T3 is the business end of the molecule and negatively impacts TSH and TRH, so it shuts down. This is that negative feedback mechanism we talked about in an earlier episode, where the hypothalamus drives the pituitary drives the thyroid, and then the thyroid makes a hormone that's measured or sensed by the pituitary and the hypothalamus to lead to the tight regulation and control of the production, so that the hypothalamic pituitary unit really decides on how much thyroid hormone is going to be produced over time. This negative feedback system is important when it comes to interpreting laboratory test studies. For example, if a patient is missing their thyroid gland, maybe it's been surgically removed or has had a disease process like Hashimoto's thyroiditis, the thyroid gland doesn't work, the T4 and the T3 levels drop, and in that setting, the pituitary and the hypothalamus sense that those levels are dropped, so they'll make more TSH. So the T4 and T3 will be low, the TSH will be high. And we can see that a patient might need thyroid hormone based on that pattern of laboratory abnormalities due to the ability for us to determine that looking at negative feedback. The reverse is true too. If a patient has an overactive thyroid like Graves' disease, or maybe they're on thyroid hormone and given too much thyroid hormone, all of that T4 and T3 that's measured in the bloodstream would be interpreted by the pituitary and hypothalamus as we're seeing too much thyroid hormone, let's shut off our signals. So the TSH level will fall, but the T4 and the T3 levels would still be high in that particular setting. In patients who have hypothalamic or pituitary disease, it's usually either the TRH is the problem or the TSH is the problem. And in that setting, when you can't make enough TRH or deliver it to the pituitary, or the pituitary can't make TSH, the thyroid gland fails. So the T4 and T3 levels will be kind of low normal. Sometimes they're frankly low, but usually they're low normal. But the TSH will be normal in that setting, and the patient may have a number of different hypothyroid symptoms and signs. Once thyroid hormone is secreted in the bloodstream, it's bound to proteins. And in fact, about 99% of T4 and T3 are bound to proteins. The rest of it is free, and the body works on the free level. That's what's biologically active. The rest is sort of, if you will, a reservoir for need that can last about a week or so, with a half-life of about a week. Those binding globulins for T4 are thyroxine binding globulin, albumin, and prealbumin. For T3, it's called transthyretin. A number of different medical conditions and hormone situations can influence these particular levels. The most important ones in clinical endocrinology are estrogens raise binding proteins, and narcotics can raise the binding proteins as well. When that happens, patients on thyroid hormone, the binding protein levels go up. Their thyroid and their pituitary can't make more hormone in response to that change. The free level drops, so we have to go up on the dose of medicine. In a normal person, the free level will simply be maintained by the hypothalamus and the pituitary. So if you have a young woman that starts birth control pills, for example, thyroxine binding globulin levels go up, that mops up T4. The pituitary and the hypothalamus recognize that because of the process of negative feedback. They ratchet up thyroid hormone production to restore the free T4 level to normal, and you reach a new steady state and everything's fine. People with pituitary disease or thyroid disease, we have to go up on their medication. The reverse is true, that if a woman has her thyroid functions adjusted while she has birth control pills and stops them, you usually have to go down on the dose. So negative feedback gives us the examples and shows us that this is how this whole system works. But keep in mind that the free hormone levels are what matters. Some laboratory studies still do total levels, and unless you do a T3 uptake to calculate the free thyroxine index, you're better off just doing a free T4 and a free T3 to assess pituitary function. And because patients have pituitary disease, the TSH is not that relevant. And I'll talk more about that in a moment. So in the setting of patients who have central hypothyroidism, I like to call it central, meaning it's related to the hypothalamic-pituitary unit, versus primary, that would be related to the thyroid. But in patients with central hypothyroidism, we see, as I had said, the T4 and T3 levels are usually frankly low or low normal. So they might be at the lower part of the normal range. And the TSH levels may be low in about 20% of patients, may be normal in 70% of patients, or may be slightly high in 10% of patients. And I used to wonder, and over the years I've learned through the research of other people, how could that be? And we'll talk about that in just a moment here. It turns out there are a number of reasons. I'll spare you the complex research that's been done to figure it out, but we know that in patients with pituitary disease or hypothalamic disease, the amount of TSH secreted in a 24-hour period is low, and it's not enough to maintain normal thyroid function. So remember, when we see that level, we're seeing that 5 seconds of time. But if you looked at the TSH levels over time in people with pituitary disease relative to people who are normal, there's less mass of TSH secreted in a 24-hour period, and that seems to affect thyroid function. The other thing is that, remember I told you that TSH is modified after the original protein is made and it's combined to the alpha subunit. And if that modification is not done correctly, which is the case when TRH is missing, you're going to secrete a molecule that has no biological activity. It can be measured in the bloodstream because it's immunologically detectable, but it doesn't have any biological activity. The analogy that I often like to use, it's like driving down the highway and you see a car on the side of the road. and that car you register with your eyes because you can see it. That's how the radioimmunoassay works. It can register that molecule. But when you're driving by, you don't know if that car works. It might not have a motor in it. It may be out of gasoline. The battery may be dead. So the function of the car is not there. And that same thing happens with hormones. Just because we can detect it in the bloodstream doesn't tell us if it's functional. And that's where we look at the T4 and the T3. And that's why the T3 level and T4 level can be low in a patient with a normal TSH. We can measure it, but it's just not a functional molecule. Or again, it might not be enough in a 24-hour period of time. The other thing that we know is that sometimes when you have pituitary disease, you lose your pulsatile secretion or your nictohemeral variation of TSH secretion, and that can result in a decrease in the mass secreted over time. Some theorize that you have to have pulsatile secretion of TSH to have normal thyroid function, that this system's meant to be rhythmic. It's not meant to be just a steady on stimulus for the thyroid to work, that you have to have that rhythmic pulsatile secretion. You have to have that nictohemeral variation where it's mostly produced at night and less during the daytime for it to work. So all of those things probably explain why you can see a, quote, normal, unquote, TSH in a patient with central hypothyroidism due to pituitary disease. Now, on the other side of the coin, some patients have TSH-producing pituitary tumors, and in them, the laboratory studies show usually T4 and T3s are elevated. Sometimes not as high as you would think, but they're usually high, and the patient may have symptoms of an overactive thyroid. Interestingly, even though the tumor produces TSH, the TSH levels aren't always elevated. They're usually either normal, but they're always on. That tumor's secreting hormone around the clock, not according to the rhythm. So the mass secreted over a period of time is higher. There was one study published in the 1990s that suggested that these tumors are maybe secreted more biologically active TSH as well. But it's probably the thyroid's being exposed to more TSH in a 24-hour period, or the biological activity is enhanced, and that's what raises the TSH and T4 levels, even though the patient has a normal TSH for that 5-second biopsy that their blood was drawn from their body. The TSH molecule is an alpha and a beta subunit. The beta subunit is specific to TSH. The alpha subunit is shared with other hormones like HCG from the placenta, LH and FSH from the pituitary gland, and that alpha subunit level is also elevated in patients with TSH-producing pituitary adenomas. So in conclusion, we use T4, T3, and TSH to measure hormone levels in patients with pituitary disease, to determine if they have symptoms of hypothyroidism, whether they're real and related to thyroid functions, and even to determine whether it's related to pituitary disease or thyroid disease, because thyroid disease is common, pituitary disease is less common, but guess what? I have a clinic full of people who have pre-existing thyroid disease long before they develop their pituitary disease. So, and they're the ones where you have to sort of ultimately abandon TSH in the interpretation of whether their dose is appropriate. Most of the patients with hypothyroidism, about 90 to 95%, have primary hypothyroidism. Something's wrong with their thyroid gland. And primary physicians are used to looking at the TSH level to decide if a dose of medication is appropriate. If you have pituitary disease or hypothalamic disease, or what we refer to as central hypothyroidism, the TSH is irrelevant. I see probably 20 patients a year where the TSH was low because it's going to be low forever because they have pituitary disease, and yet the primary physician looks at that level and ratchets down the dose of thyroid hormone. The same is true when the labs are repeated 6 to 8 weeks later. The dose is dropped again. Ultimately, patients come to me feeling tired and fatigued and basically miserable on just a fraction of the intended thyroid hormone dose, and I recognize what had happened and increased that dose. And probably the most important thing that I could tell those of you who are patients, or those of you who are in training or already in practice, is if you have a patient with central hypothyroidism, don't use the TSH to monitor their replacement therapy. Go with the T4 and T3 and aim for levels that are normal or slightly in the upper part of the normal range, but certainly try to pair those levels with the clinical symptoms and signs of the patient. So thanks for your attention, and look to future episodes to learn more.
This is Jorge Fascinetti, co-founder and chairman. Pituitary World News is dedicated to produce content that informs and educates. We are a non-profit organization and as such rely on contributions to fund all these initiatives. We have exciting plans for 2025. If you'd like to learn more about our plans and help, please visit pituitaryworldnews.org and click on the donate button. Every contribution helps, no matter the size. You can also help by sharing all the information available on the Pituitary World News website at pituitaryworldnews.org. We welcome your comments and suggestions. Thank you, and thank you very much for watching.